Well, good morning, everyone, and welcome to the surgical grand round this morning. It's a pleasure to be here. I'm James FitzGerald. I'm one of the neurosurgeons. I'll give the talk today, and it's a pleasure to talk about what is a unique, I think, partnership between the university and OUH, which has got fantastic implications both for patient care and for research. I'm going to talk, it's actually a multifaceted enterprise. AMIIC itself is doing much more than what we're doing. I'm really going to focus on the neuro bit of it and the story of how we got involved with AMIIC. That will show some of the work we've been doing for the NHS and also some of the work we've been doing in the first phases of our research. I have some disclosures which of relevance include some of the manufacturers of devices that we implant. So this is just a little bit of background about functional neurosurgery in Oxford, and what functional neurosurgery means is it's the type of neurosurgery that actually modifies or modulates the way the nervous system works. Most of neurosurgery actually is orthopedic surgery or oncological surgery or vascular surgery that is in or near the brain. We specialize with modifying brain function, and that's done through the implantation of electrodes, which in many ways resemble heart pacemakers, electrical wiring attached to little boxes that go under the skin that have electronics and batteries that generate small electrical pulses that treat the conditions that we're interested in. And those conditions fall into broadly two categories. Firstly, we do deep brain stimulation, which is stimulation of deep basal ganglia nuclei in the brain to treat neurological movement disorders, the most common of those being Parkinson's disease. And then we also have a large practice in neuromodulation for pain, and largely this encompasses procedures that involve electrodes being inserted epidurally into the spine, either as spinal cord stimulators or stimulators of the dorsal ganglia, which is what you can see down there on the bottom right. You can see an electrode there in the exit frame and overlying the dorsal ganglion at L4 and L5, and that was done to treat pain in the lower limbs. Now, one of the things about these procedures is particularly the pain procedures over recent years have become in many cases percutaneous. You'll see here, I'll just play in the background a video of me putting in the dorsal root ganglion stimulator wire, and you can see it's all done through a needle under radiological guidance. Doing this in theatre can be frustrating. It can take 30 to 40 minutes at times waiting for a very busy radiographer to come to do the case. It is done with a C-arm. The C-arms have to be moved from AP to lateral views repeatedly during the procedure, which has time, potential risks of sterility, and is suboptimal because you can't see both views at the same time. And all of this leads to the idea that actually, wouldn't it be good if we could do it using biplane fluoroscopy? And a nosy walk on my part down the corridor to the main John Radcliffe, where I rarely go, and the diversion off to the right into the bottom of the cardiac building took me to AMIIC, the Acute Vascular Imaging Centre, which has been there really since the beginnings of the move in the West Wing, and was originally intended to treat stroke, but for one reason or another, that didn't really happen to a great extent. It took a long time for the stroke service, which is now flourishing, to get off the ground. Ultimately, this chap, Professor Antoniadis, took over the running of AMIIC, of AVIC as it was and AMIIC as it is now, and has transformed it. And we had initial discussions at the end of 2019 about the potential for neurosurgery to do some procedures in the facility. We thought these were the potential benefits. To the NHS, it could provide capacity to tackle what was an enormous waiting time already. We had waits of around a year for our pain procedures, which for people who are in really desperate condition with very, very poor quality of life seemed like a very long time. To the NHS also, generating extra capacity would require no real capital investment because the equipment is already there. For the university, We could provide NHS business that would bring a regular income to help smooth the peaks and troughs of grant applications. And we would also look jointly to build an infrastructure for doing research studies. And research in patients having this kind of intervention is hard to do in the hard-pressed resource environment of the NHS, where the pressures of the clinical waiting list are extreme. Treating NHS patients with this kind of procedure is not something the university had really done much of before. But there was increasing recognition that research in these types of interventions and devices requires integration, increased involvement, because nobody comes to have one of these put in on a research basis, at least not many. There are some studies which have been done purely for research, but a lot of the work is done in patients who are having these procedures anyway, and we bolt on some research that opportunistically uses some aspects of what we're doing to study a disease or physiology. Now, the key people I want to mention up front, Harris himself, also Sheena Thomas, who's the lead radiographer that we got involved with at the beginning in AMIIC. And also I'd really like to mention John Chatwin, who's our operational services manager, who's been a stalwart supporter of this, that unfortunately passed away just a few days ago. Now, those discussions happened at the end of 2019 initially, and then we had a bad year, as I'm sure everybody did. We had COVID wave 1, and then when everybody else was starting to get up and running again after the first wave, we had the legacy in the West Wing of a snowstorm the previous year in the middle of summer, which was actually bits of air conditioning material falling through the ceiling of our theatre. That required a refit, which took place after the first COVID wave and ended shortly before the second. So overall, we had a one-year outage, and a one-year wait prior to COVID became a 2-year wait afterwards. This really gave extra impetus to the project of using AMIIC, and the elective recovery fund coming in after COVID really helped as well, and that's funded a lot of the work to date. At that time, there was a refurbishment going on. AMIIC was being transformed, the cath lab was being refurbished, the MRI scanner was being replaced, and I'll come to that again in a minute. A lot of work happened. It took the units out for a few months, but then it was much, much better afterwards. You can see a lot of the work's going on here. This involved various things, including plumbing and gas supplies, which became important for anaesthesia. And this is a new scanner, more of which later. The unit had from the outset very much an aim to blend clinical and research work. Several research themes envisaged, not just cardiac, which is obviously where it started, cardiac and vascular, but also there was neuro involvement. It's not just us now, neuroradiology using the unit as well. There was dedicated work to developing CT imaging, and there's also a strong theme running through it of big data and artificial intelligence, which we will hopefully tap into in due course. And there's a mission statement: to deliver state-of-the-art multidisciplinary research by providing the infrastructure linking interventional non-invasive imaging, artificial intelligence, big data capabilities, and at the same time supporting clinical care, working strongly, closely together with the Medical Sciences Division and importantly OUH. There are many, many people involved in this. These are many of the principal people, but there are others too. And this is what the facility holds. Level 1 has the new CT scanner suite. It has a large cardiac cath lab, which now doubles as an operating theatre for us. A lot of work was done on that to get that ready. New flooring, infection control procedures, and so on. There's now also a 3-bedded recovery area, and most of the patients coming through are day cases. There's a very fully fitted out unit. Above, there are offices, seminar room, and a large data processing service. This is the experience with the new CT scanner. This goes well beyond what we do. Obviously, I would just highlight that on the bottom right says CT head. Most of those are ours, and I'll come back to that in a little while. This required significant investment. And I really would like to emphasize that there's been investment on both sides, but particularly from AMIIC, where a new anaesthetic machine costs £50,000 to £100,000. The recovery area has expanded. Various other sundry items, none of which are cheap, were purchased. 4 staff have now been trained to scrub for neuro cases. They obviously do other things as well, but they've been trained to help with our cases specifically. And an anaesthetic practitioner has been hired through agency. From the NHS side, we have 2 anaesthetists now job planned to the unit. I'd like to highlight Jane Quinlan, who's been the clinical director of anaesthetics, who's been incredibly supportive in getting that done. So it's been a big joint effort from a lot of people. And you can't overestimate the importance of a can-do attitude, and it's really had that feeling to it all the way through. It took something like 18 months to set up. There were a lot of lists that fell by the wayside because of lack of person A or person B. You'd have an anaesthetist but no ODP. You'd have an ODP but no anaesthetist. You'd have no one available to scrub. And this happened many times over the first period. And the key thing is that everybody was willing to stick with it. And again, I'd like to thank our management in the NHS for sticking with it through that time, because it must have seemed like a very patchy service to begin with. It has, however, now been up and running reliably for a year, and in that time we've done something like 150 operations in the unit, all of which have gone smoothly with no major complications. These include fairly much the full portfolio of our pain work. So we're putting in spinal cord stimulators, epidural electrodes in the thoracic spine percutaneously. There are some still going in open in the West Wing, but the majority of them are now done in AMIIC. We put in dorsal ganglion stimulators like the one you saw a minute ago. We've put in peripheral nerve stimulators, and recently we've begun to do injections into the trigeminal ganglion. And the importance of this, although it's a relatively quick and straightforward procedure, as it requires general anaesthesia. And so this has been our first foray into the use of GA in the unit, having previously been doing everything under local and sedation. We've cut the waits dramatically. From being at 2 years, we're now well under 12 months for most pain procedures. And as I said, the really important thing from a university point of view is we now have an infrastructure for research which we never had before, and we have several studies planned, which we hope to carry out in the unit. Deep brain stimulation is one of the things we do. Now, this is a procedure that we haven't actually yet done in AMIIC. DBS is all about the surgery of getting the ends of 2 electrodes into very, very precise areas of the brain. The commonest area we target is something called the subthalamic nucleus. It's a few millimeters across, and it lies underneath the thalamus in the midbrain, so the upper part of the brainstem. It's very small. The leads you're getting there are very small. It's quite a comparatively long way from the outside down there. And so getting them on trajectory is the name of the game. And every single surgical refinement really has been aimed at doing that with greater and greater accuracy. This is the standard workflow, and this is on top left. You start at the top left, you've got a patient there who's had this frame bolted to their head. The gold-coloured ring is attached with pins that pierce the skin and grip the skull. That's necessary. That technology is decades, probably even 100 years old, and that is there to provide a solid, firm basis relative to the skull for us to compute coordinates from to reach the target. Once that's on, the patient goes through a scanner. It's a CT scan there. We've done an MRI beforehand. The MRI gets merged to the CT to give us more detail. We then have a workstation, which we use to do a detailed plan, which you can see on the right there. We take the coordinates generated from that, and we put them in this black thing, which is essentially scaffolding that sits on that base ring, which carries, as you can see, the top of the arc on the top of it, a holder which allows us to guide a drill and then an electrode to a very precise point in the brain. You can see that going on in the bottom in the middle picture on the bottom row. Those electrodes are then tunneled via extension wires to a battery, which is what you can see at the bottom right, and that's usually on the upper chest. But again, the whole point of the procedure is accurate electrode placement. Now, there have been many innovations. Sorry, I should just explain that this picture shows the areas we're aiming for. So you can see there in light blue, something called substantia nigra in the midline, and just to the left of that, in green, is the subthalamic nucleus, and that's the very small nucleus we're aiming for in most of these cases. The alternative place to stimulate is the GPI, which is the globus pallidus internus, which is there in yellow. Not quite so small, but because it extends further in the other directions that you don't see on the scan. But it's still not a very big place to aim for. So you can see that we need to be there or thereabouts. And by thereabouts, I mean within about 1.5 millimeters. Now, there have been many advances over the years, and the technology has been around for about 30 years in its modern incarnation. But over that time, things have changed a lot incrementally, one after another. So we've got the most amazing implanted batteries now. So these are rechargeable. They last 25 years, which means that after you've had it for 25 years, recharging it perhaps once a week, you'll probably need to charge it twice a week. So if you compare that to the performance of your mobile phone after 18 months, you'll see what kind of advance that is in terms of technology. From having a situation like cardiac pacemakers of yesteryear, where nobody could go anywhere near an MRI scanner with one of these in, we now have devices that are MR conditional, which means you can't have everything done, but for diagnostic purposes, most things are safe. We have the first devices that are in situ upgradable. So these things now have little computers in them. They're probably as intelligent as a couple of generations ago, a smartphone. And you can reflash the firmware. So if there's any upgrade needed, you may not anymore need to take the device out of the patient. And most excitingly recently, we have remote programming. So we're now able to log into patients' devices, which communicate with their phone via Bluetooth, and then their phone is on their Wi-Fi. We can now hold a video consultation and simultaneously see the settings on their device and adjust it as necessary. So if someone's tremor has got worse or their pain isn't responding in the way it was, we can interrogate the device remotely to see if the battery's okay, make sure the leads are intact, and adjust the settings. One of the big innovations that's come about in recent years is a thing called directional simulation. So this is a rendering of a study where somebody took a collection of electrodes that have been implanted in the subthalamic nucleus, which here is shown in orange. And you can see these are the electrodes from many cases superimposed on a subthalamic nucleus, which is a sort of average rendering of where the STN is. And you can see that they're not all in exactly the same spot, and if targeting was perfect, you would just see one wire, but what you see is a whole clump of them. And you can see that some of them appear to be slightly less well within the subthalamic nucleus than others. And this is important because you do want to stimulate that nucleus, but you also very much don't want to stimulate things nearby. This is an area with lots of closely packed circuitry, and it's easy to generate side effects if your stimulation field spreads to adjacent structures. Now, you can see that there are several contacts arranged along the wire at the end, and it's always been possible to adjust the vertical position of the stimulation by moving from one contact to another, but never before to move it sideways. And how do you do that? Well, you do that by splitting these ring contacts around the end of the wire into segments. And this allows you to be able to shift the stimulation slightly, not far, to one side or the other. But small distances are important here. The lead is 1 millimeter or 1.2 millimeters wide. And moving the stimulation field from one side of it to the other gives you a couple of millimeters of adjustment. And as I said before, the nuclei we're aiming for are only a few millimeters in size. So that can easily move you from just outside to just inside for a lead that's not ideally placed, but good enough. This is one of the new electrodes. You can see what I mean about the segmented contacts. Just the middle two of those on this wire are segmented. So at those levels, you can turn on and off those contacts independently and have the stimulation on one side or the other, or if you turn all of them on all the way around. You can see the effect here. These are some wires that have been put in egg white and turned on, and it coagulates the egg white. And you can see there on the leftmost picture the standard symmetrical distribution of charge. Where it's cooked the egg white, that's where the brain's being stimulated. It doesn't have this effect on the brain, fortunately, but it just shows the areas being stimulated. And if you look further over to the left, to the right, you can see that individual segments have been turned on, 2 of them in the third picture over and just 1 in the fourth picture over on the right. You can understand then how the stimulation can be moved from side to side. Now this is what one of these leads looks like. It's 1 millimeter and a bit in diameter, as you can see. The ruler on the right is in millimeter gradations, and you can probably just about make out the middle 2 contacts of the 4 on the right that there's a split down them, and that's the split between the various segments of the contact. Further over to the right, you can see a longer metal object, which is a direction marker. So you can see a couple of rings, and then there's this bar running up and down, which is only present on one side of the lead. And this is supposed to be able to tell you on imaging afterwards which way round it is, because we need to know that to program it. Unfortunately, what you see on a post-operative CT through the level of the directional segments is just a blob. So the artifact that you see there is just from the metal of the contacts. Resolving the individual components is well beyond standard CT. So we have these new electrodes. They definitely can improve the therapeutic window. So that's the difference between effect and side effect. So when you turn these leads on, you get stimulation effect you want. You turn them a bit further, and you get spread of stimulation to adjacent structures and side effects. With the directional leads, you can improve that by not stimulating in the direction of side effect structures. But the cost for this is they take about 3 times as long to get the programming right. The number of combinations of pulse widths, pulse frequencies, amplitudes, and the number of different contacts at the end of this gives an uncountable number of combinations of stimulation that can be delivered. And traditional methods have relied upon iterative approaches of trying them out one at a time, trying various parameters out on each contact, and having multiple programming sessions to do that, because it can take hours. So there's a drive now towards software assistance of programming. In other words, having the lead and the target nucleus in the memory of a computer, and the computer deciding what current should be delivered to each contact in order to generate a field of the right shape and distribution. But this is all predicated on knowing which way around the lead is. So then another opportunity in AMIIC arose, because one day the MRI in AMIIC disappeared and a new CT appeared. This is it coming through the door, but it's not just any CT. It's a very, very high resolution CT, and it uses a brand new type of detector. And it came in principally for the cardiac work that Harris does. And one of the things it can do is resolve bits of metal much, much better. So you can see some cardiac stents there on the right, and you can see the view that you get of them with a standard CT, which is the second image along, and with a photon counting CT, which is what this technology is called, which is the fourth image along. And you can see how much sharper and clearer it is. This is what photon counting CT means. So a standard detector for a CT scanner or an image intensifier involves something called a scintillator. So when X-ray photons pass through patients, they go into a crystal which turns them into visible light. That visible light gets scattered in various directions, but a proportion of it ends up going into photodiodes below, and they generate a current in a response, and the current in each of those is what gets taken to compute pixels in the image. Now, unfortunately, there is noise current, so the photodiodes will pass some current even without any incident photons. And also that there's a requirement for scepter, so you need to have partitions in the detector because the photons get spread laterally. So in order to avoid degradation due to that, you have to have partitions. That takes up some space. The noise current degrades the image. The standard way to get around that is simply to turn up the dose. This will improve your signal to noise, but it obviously is undesirable. In a photon counting detector, you have no scintillator there. The X-rays go straight into a semiconductor, releases electrons, and you can remarkably see each individual X-ray photon as a single pulse in the output. That means that you can discern each photon that's incident, and you can count them, and hence the name photon counting CT. And the counted X-rays in each pixel are what the image is formed from. This is a digital equivalent of an analog technology in the standard detector. The standard detector simply measures the amount of light in each area, whereas the photon counting detector counts the individual X-ray photons. Now, the bursts of current from each photon are large enough that you can put a threshold on, more or less completely suppress background noise. So the noise is removed. You can also reduce the size of the detector elements considerably and increase the scanner resolution. So the arrival of this scanner was very exciting. And we said, we'll ask the question of what can we do for DBS patients? Can we resolve the electrode segments on the leads? And the short answer is yes. So this is a scan of two DBS leads in situ in the subthalamic nuclei of patients. And you can see straight away that you can resolve the individual components. You can see the splits in the rings of the directional leads. And remember, each one of these is 1.2 millimeters across. So the resolution here is unparalleled in CT. It's down to something just over 1/10 of a millimeter. And you can see again here, if you then look at the lead axially, at the top left, you can see a section through the segmented lead level, and you can see the individual segments of the lead. And if you look at the top right, that little curve is the representation of that directional marker. So we can tell from that that this lead is implanted with the marker pointing anterolaterally. This works for all the major lead types. There's 3 different manufacturers there on the left. Each one of them, you can see the segmented contacts. They all have slightly differently made directional markers, but they can all be resolved. And the next step is to take this and put it back into our programming devices. So here we have a rendering of the directional lead, and in blue there you have the subthalamic nucleus of the patient, which has been segmented out from their MRI scan. And you can see straight away that the middle 2 contacts, the segmented level contacts, are well placed in the STN, and you would probably choose the ones you can see on the right of the segmented levels as the most appropriate to use for that patient. This is a comparison with the best existing way of doing this. There's a technique developed to try to detect the direction of the lead from artifacts on a CT scan. So you can take the blob that we saw before, put it through a computer and analyze it. And top left, you see here, we've got our CT superimposed on a prediction from artifact analysis of the lead position from a major provider of guidance systems. And you can see they've done a really good job. So the prediction in orange exactly overlaps the lead we could see. The problem is that although the direction, although the position in the vertical direction is well established, and the position is usually well, and the orientation, the rotational orientation around the axis is usually well established, there is a significant proportion of times where it's out by 180 degrees. If you look at the bottom right, you can see that the orange colored electrode has the software has put the arrow on and has detected correctly the orientation marker. But the green one, it's out by 180 degrees. And we found that this was happening in about 1 case in 3, which really makes it not fit for purpose for guiding programming. taking it a step further, we decided to look at the insides of the leads and see whether we can resolve even smaller components. And you can see particularly clearly at the top right here, that is the directional marker you can see more or less directly under the letter B, which is itself 1.2 millimeters across. And within the lead shaft up to the right, you can see the individual filaments of wire running to the contacts, which are something like 1/10 of a millimeter across. And you can see them very clearly. You can see it in cross section in panel C there. And we've used this already to inspect leads where we suspect there may be a fracture in one of the conductors because they're not working well. And where that occurs, you can see it very clearly. This is just a show of just an example of what's happening to leads now that the idea of directionality is caught on. The leads are becoming ever more complicated, and the sort of current de facto standard on the left there has eight contacts on the end of it, 3 segments, 2 levels, and 2 complete rings. The next generation, which is now in trials, has 16. And this really takes the standard iterative programming techniques well outside the realms of practicality. And the software guided systems really have to take over now. And we've already started to use this method of visualizing orientation to program our patients with substantial reductions in programming time and quicker travel to the ultimately best solution. All of which comes at reduced dose. Because the technology reduces noise substantially, there's no need any longer to have a significant to have a certain dose to preserve signal to noise ratio, and we found that those can be reduced. And in the first study we did, first 15 patients we did, the average reduction was 12%, and I'm sure we'll be able to drive that lower. So just to summarize today, this has taken a long time to set up, but it's now working really well. We've got substantial capacity for the NHS. We've reduced our waiting list by more than waiting time, sorry, by more than half. Really importantly, we have research infrastructure going forward. And I would just say again, the importance of the people involved and a can-do attitude can't be overstated. And everybody involved has had that mentality and just made it work. What's our next step? Well, I've shown you that we've done pain procedures in AMIIC. What we really want to do next is deep brain stimulation. And some people sort of look at me crazily and say you want to do brain surgery in a cath lab. But actually it's perfectly possible. In Oxford, we now have an operating robot, which helps. This has cut our procedure times down. It's improved our accuracy somewhat. Some of our patients who are in their 60s and 70s look at me strangely when I talk about a robot operating on them, and I just reassure them that that's not what it means. It has helped with our accuracy. Patients tolerate it very well, even those who are having surgery awake, which is still a few of them. And it will be an enabling step in allowing us to do this in AMIIC. We do DBS in Oxford as a more or less percutaneous procedure. The incisions there in blue are maybe 1 centimetre long. The holes in the skull are 4 millimetres. So there's virtually zero postoperative scalp pain. We haven't quite got this today case yet, but it will happen. The wounds are simply stitched and glued with no requirement for any further care to them afterwards. All our patients at the moment are in for a single night and go home the next morning. There are no large incisions in this procedure, which is what makes it suitable for use in cath lab. And along with that, we've got some research questions building for DBS. First question is, can we, with a CT scan, directly image subthalamic nucleus, which is our target, which currently we require an MRI scan for, and that MRI has to be fused to the CT, which inevitably introduces some error in registration. So the question is, with the photon counting CT, might we be able to dispense with that? That's it for now. That's where we're up to. AMIIC's had many supporters. Just like to acknowledge all of the funders. As you can see, many of them are not neurosurgical. but it's been a big effort, big partnership, with many specialties involved. And as I say, we've only really talked about one little part of it, which is neurosurgery, but I think it's a massive asset for the hospital and the university more widely than that. Thank you.